Hello, and welcome to the Parkinson's Foundation's Wellness Wednesday. I'm Nancy Nealon, a community program manager for the Parkinson's Foundation. Today, we're really pleased to introduce a new program to our PD Health at Home series, Living with Parkinson's, or Parkinson's 101, What You and Your Family Should Know. Joining me behind the scenes from the Foundation's community engagement team are Erin McGee and Danielle Akpalo. Erin, Danielle, and I warmly welcome you to this program. I'm logged in from Rochester, New York, and we'd love to know where you're tuning in from. Feel free to share your location by typing it into the Q&A icon at the bottom of your Zoom banner. You are not alone, and your Parkinson's community is here with you today. And furthermore, I'm going to share with you some specific information about the foundation and what we do and how we're doing it. We have someone watching from the New York City area, and I'm sure there will be more people tuning in as well. The Parkinson's Foundation hosts virtual events on Monday, Wednesdays, and Fridays. To learn more and to register, please visit parkinson.org/pdhealth. We have a great variety of topics offered, so don't miss out. Please go ahead and visit that site. In particular, I know that there are a lot of care partners or caregivers watching today, and we have lots to cover, but I wanted to make a special point and draw special attention to a virtual program that's designed just for care partners. I encourage you to participate in our next Care Partner Town Hall. You'll see on the screen, you can register for that as soon as we're done with the program today. So about the Parkinson's Foundation, what we do. We pursue three goals: ensuring better care for everyone, understanding Parkinson's through research, and educating and empowering the Parkinson's community. All of this we do building on the energy, experience, and passion of the global Parkinson's community. The foundation has a wide variety of free resources that you can access. Numerous books, fact sheets, educational events, podcasts, our Wear and Care Kit, which can be used when someone with Parkinson's is hospitalized. In addition, our helpline is staffed by a very special, talented group of Parkinson's specialists. The toll-free number is 1-800-473-4636 or 1-800-4PD-INFO. For tomorrow, the Parkinson's Foundation is helping by starting a special initiative called PD Generation, and that is helping to map the future of Parkinson's disease. I encourage you to check this out, participate if you can. You can visit our website directly on the landing page. You'll find lots of information about PD Gene. And for all of us, you can help support all that we do, our research, our programs, our education, and so much more by participating in our incredible special event, Moving Day, a walk for Parkinson's. Visit movingdaywalk.org to learn more. We look forward to welcoming you to those events in the future. And two things that I just want to make sure everyone knows and takes with them to support your journey: our helpline, 1-800-4PD-INFO, and our website, parkinson.org, which has so much information you can use and rely on. Next, I'm very honored to recognize the Light of Day Foundation. Their generosity has made our PD Health at Home series possible. Thank you to everyone at the Light of Day Foundation for supporting the Parkinson's Foundation. And now, without further ado, I am especially honored to welcome our speaker, Dr. Jori Fleisher. Dr. Fleisher is a fellowship-trained movement disorders neurologist with a special interest in understanding the needs of individuals and families who are living with advanced Parkinson's disease and related disorders. She also has a special interest in designing new models of care to better serve the Parkinson's community. After 3 years on the faculty at New York University, she joined the Rush University Medical Center in Chicago in the Parkinson's disease and movement disorders program in 2017, where today she continues to see patients and conduct research. And one quote I found from Dr. Fleisher that I think reflects who she is as a person, as a doctor, is something she said about herself, which is, quote, "My goal is to help you do everything that you want to do today, because that will help you doing as well as possible in the future." Dr. Fleisher, thank you so much. We really anticipate and are excited about your presentation.
Hi, everyone. Thank you so much for the kind introduction and for the opportunity to speak with you today. I'm so glad that you're here and you're joining this program. So let's talk about living with Parkinson's and what you and your family should know. There we go. So here's what we'll cover today. We'll talk about what Parkinson's disease really is, what causes it, what are some common symptoms, how do we manage the disease so that you can live well, and Parkinson's and research. So what is Parkinson's disease? Parkinson's is a progressive brain disorder. Sometimes we call this a neurodegenerative disease, meaning that there are populations of brain cells or neurons that die off before they should. And there's nothing that you did to make this happen. There is no cure right now for Parkinson's disease, but symptoms can be treated, and there's tremendous reason for hope. Parkinson's can affect movement. We think of it as a movement disorder, but it can also affect a number of other symptoms and systems of the body, including mood and thinking. Healthy lifestyle choices can help maintain quality of life, and we'll dive into that in a bit. But if you take nothing else away from this presentation, please know that people with Parkinson's disease can live well for many, many years with expert care, support, and the right resources. You don't need to do it alone, and we are here to help. So, who gets Parkinson's disease? I think a lot of people are surprised when they hear these numbers, but an estimated 1 million people in the US have Parkinson's disease, 10 million or more worldwide, and 60,000 people are diagnosed with Parkinson's every year. It's the second most common neurodegenerative disease after Alzheimer's disease. Parkinson's can affect anyone. Parkinson's doesn't care about race, ethnicity, gender, or sex. And most people are over the age of 60 when they're diagnosed, but a small number have what we call young onset Parkinson's disease or early onset Parkinson's disease. And this typically means being diagnosed younger than 50. And there's a very, very small fraction of people who are diagnosed earlier than that, so in their 20s or even earlier. And we refer to those individuals as having juvenile onset Parkinson's disease. But again, that's exceptionally rare. So what causes Parkinson's disease? Age is the #1 risk factor for developing Parkinson's disease. The older a person is, the higher the risk of developing Parkinson's. Overall, though, the cause is unknown. Scientists believe that it's a combination of genetic and environmental factors that contribute to an increased risk for most people. So Parkinson's is rarely hereditary in the sense that only a small number of people have a gene that runs in their family that guarantees that they will develop Parkinson's disease. That's fairly rare. There are several genes that have been identified and that can be tested for, where if the person tests positive for those genes, we know that they have a higher risk compared to someone else in the population who doesn't have that genetic change, but it doesn't necessarily guarantee that they will develop Parkinson's disease. And for some people that have Parkinson's, frequently they ask, even if they have been genetically tested and confirmed to have one of these mutations, what does this mean for my family? Having the mutation themselves doesn't necessarily mean that their loved ones will have that mutation, or if they do, that a loved one with that mutation will necessarily develop Parkinson's themselves. So it increases the risk, but doesn't guarantee that a person will have it. Let's see if we can. In addition, there are some studies that have demonstrated that prolonged occupational exposure to certain chemicals like certain pesticides, heavy metals, and solvents, or even air pollution are associated with an elevated risk of developing Parkinson's. But again, to be put into context is that many people are exposed to these things who do not develop PD. So it's not, spraying pesticides on your lawn on the weekend in the summer. That's not what did it. We don't think. It's probably a combination of many things. So I like to think about this as almost a combination lock. You need the right setup genetically and the right setup of environmental things, and they have to line up in just the right way, or maybe just the wrong way, and that leads to Parkinson's disease. So there are other risk factors, as I mentioned. Older age is the biggest risk factor. There's studies reporting that certain traumatic brain injury can be associated with Parkinson's. I want to comment on the thought that this comes up in the clinic frequently, is that sometimes people will say that symptoms appeared suddenly after a severe shock or a severe stressor. There are descriptions like this, in fact, dating back centuries. But Parkinson's is very slowly progressive. By the time movement symptoms arise, Parkinson's has been going on for years in the background, maybe with very subtle symptoms that we only recognize when we really dig deep and ask questions. And maybe there were no symptoms that were noticeable, but it seems unlikely that any single event causes the disease. For example, I have a patient who swears that their snowblower caused their tremor. They were fine until that great blizzard when they got the snowblower out. But when we dig back, they had some other non-motor symptoms and constipation and all kinds of other things. And just based on the science, it's probably not the snowblower's fault. They were probably en route to developing full-blown PD anyways. So what's really happening in the brain? Let's dive into this. So here, hopefully you can see my pointer. So Parkinson's occurs when the nerve cells in the brain that produce a neurotransmitter or a chemical called dopamine start to malfunction and die off. So if we look over here, this is a normal neuron, and this is the end of the neuron. This is sort of the fingers reaching out to communicate with the neighboring neuron that needs to receive dopamine. So this neuron makes dopamine, releases it into this space, into the synapse, and the dopamine goes to this dopamine receptor neuron, turns it on, and that leads to normal movement. So in Parkinson's, for reasons that we still don't understand what sort of starts this cascade, these dopamine producing neurons start to die off over time. So there are fewer and fewer of them. And so there's less dopamine being released. The dopamine receptors are still there. They still need to see that dopamine in order to work on lots of functions in the body, including coordination of movement, so the speed of movement, but also speech, sleep, cognition, mood, and more. And what we used to think of as really a dopamine disease, although that was sort of the first thing described in Parkinson's, we now know that other neurotransmitters, other chemicals in the brain are also affected. And this includes things like norepinephrine, acetylcholine, and serotonin. And I bring this up because those chemicals really help mediate mood and lots of other functions in the body. And so we will talk soon about mood symptoms in Parkinson's and other things that go on. These are as much chemical changes as the tremor and the movement symptoms that we think of more frequently. So researchers are working on ways to stop or slow down the loss of these cells. So what did you know about symptoms? Parkinson's affects many systems in the body, including mood and thinking. And we call Parkinson's a movement disorder. I'm a movement disorder specialist because we think commonly of the tremors, the slowness of movement, and the stiffness that it can cause. Symptoms vary from person to person. We can't say this enough. If you've seen one person with Parkinson's, you've seen one person with Parkinson's. If you get the sense going to a support group or an exercise class for people with PD that everyone else has different symptoms and they're all on different medication regimens than you, you're right, because everyone has a sort of different presentation of their PD and needs something a little bit different. So let's talk about some of the motor symptoms first. So tremor or shaking, which looks like this, or could look like that in a foot or in the jaw. Tremor is often one of the things that brings people to care. It's a noticeable symptom for many people. Typically, it's in the hand or the foot, but it could be in the head, neck, or jaw. It's often the most recognized symptom, but not all people with Parkinson's develop a tremor. So about 30% of people with Parkinson's never have a tremor. And we call this a resting tremor, which means that for the most part, early on or throughout the course of the disease, that tremor is there when you're not using that hand or that foot, when it's just resting on the arm of the couch or sitting, close to the keyboard, but you're not typing. That's when you might notice it, or often when a family member might notice that the hand is shaking. And if you look at it, if you pay attention to it, if you move it around or change positions, you can make that tremor go away for a certain period of time. Slowness and trouble with movement, though, or this fancy word of bradykinesia. So this is really the hallmark of Parkinson's disease. You really can't be considered to have Parkinson's disease without bradykinesia. It's the slowness and the decrement that really leads to this diagnosis. So your doctor may have you tap or clap or do these funny movements. And what we're looking for are, do the movements stay big and large, or are they slower instead of fast? Do they get smaller as you go and teeny tiny taps? That's really the hallmark of Parkinson's disease. This can show up in daily life in subtle ways. So more difficulty taking longer to button tiny buttons, to do cuffs, to zip zippers, to prepare food, to brush your teeth, starting big on one side, but getting tiny and more cramped as you go. Shaving can get difficult. And often because these changes are very slow and they don't happen overnight, thankfully, if we ask a person, they may say, no, I've always been this slow, or, I've lagged behind the group when we're walking for years, but those may be subtle earlier symptoms. Stiffness can be common, stiffness in the arms, legs, neck or hips, and trouble with walking and balance. Let's talk about some of these non-motor symptoms. So as I mentioned, mood is a very common symptom. So depression can commonly occur in Parkinson's. And I want to put a point on, this is not just, I was just diagnosed with Parkinson's, you'd feel sad too. Yes, that is an acceptable and normal response. People have what's called an adjustment disorder when they receive a difficult diagnosis. The depression that we're talking about is separate from that. The depression we're talking about is feelings of sadness, feeling blue, feeling hopeless, feeling worried, and that can start years before a tremor or slowness or stiffness, and that can happen at any point during the course of the disease. If it is a change from your normal baseline, it may reflect some of these other chemical changes going on that are part of Parkinson's disease. Similarly, anxiety is also a very common symptom in Parkinson's, and it can be a generalized anxiety, feeling more nervous or more anxious than you previously did, or it can be very situation specific. So really getting worried about timing of appointments and needing to leave, or worrying about traffic. And so giving yourself an extra 2 hours, arriving at the office very, very early. All of these, if they're changes, you should talk with your doctor about them. Also, apathy, this sort of lack of motivation, lack of feeling or interest, even separate from depression. So just feeling kind of loss of oomph to do the things that you would normally want to do. That's very common. So Parkinson's can affect cognition or thinking and memory in terms of trouble paying attention, trouble learning new things, trouble finding the words that you want to find, slower thinking, even if the quality of the thinking is great, and difficulty remembering words or names. Frequently, this starts with that tip of the tongue phenomenon. The person standing in front of you, you can't think of their name. And as soon as they walk away, of course, you remember their name. And while these all can happen with normal aging, they're more common with Parkinson's. Sometimes people have trouble with softer speech, or as they get to the end of their sentences, they start to trail off and it becomes harder and harder to hear them. Sometimes people have difficulty falling asleep or staying asleep, and people can have what's called a REM sleep behavior disorder, which is, and this can precede motor symptoms by many years, if not decades. Instead of having vivid dreams, but if a person's in the bedroom next to you, they don't know what you're dreaming about, REM behavior disorder means you are acting out your dreams. You may be kicking, thrashing, punching, turning over in bed, having loud conversations. It's like the switch that should turn off muscles while sleeping. That switch doesn't get flipped in people with Parkinson's. People can report fatigue. So even if you do have a good restful night of sleep, still feeling very sleepy during the day or having little energy. Constipation is incredibly common, and hallucinations, typically later in the disease. So this is a great, just sort of a handy reminder of 10 early signs of Parkinson's disease. We've covered several of these, but tremor, small, cramped, tiny handwriting or micrographia, loss of a sense of smell. And I want to highlight that this is not COVID related. Parkinson's was associated with a loss of sense of smell long before COVID. And this is typically gradual. This is not sudden in onset. Trouble with sleeping, as I mentioned, trouble with moving or walking, constipation is a big one, soft or low voice, a masked face or diminished facial expression, dizziness or fainting, especially upon standing up or changing positions, feeling a little bit lightheaded, and a stooped posture or hunched over posture. So, how do we diagnose Parkinson's disease? The only way to diagnose Parkinson's disease with 100% accuracy, 100% certainty, is to look at a person's brain under a microscope, which is not something that we do while a person is still using that brain. So how do we diagnose Parkinson's then with some degree of certainty during life? Making an accurate diagnosis in its early stages especially can be difficult, but a skilled physician can come to a pretty reasoned conclusion that this is Parkinson's disease with a high degree of accuracy. It's important to remember that 2 of the 4 main symptoms must be present over a period of time for a neurologist to consider a PD diagnosis. And those symptoms are bradykinesia, that's slowness and movements getting smaller. You have to have that. And then 1 of the following 3, which is that tremor, especially at rest, rigidity or stiffness of the muscles, and postural instability or changes with walking, changes with balance, or falls. If you have that bradykinesia, the slowness, and 1 of those other 3, then we're in that category of Parkinsonism. And so a detailed history, the reason that your neurologist or that the doctor will ask you 1,000 questions is to rule in or rule out Parkinson's disease, to try to get as close to certainty as we possibly can. They will ask about your medical problems, current and past medications, and then do a neurological exam to assess characteristic motor and non-motor features. So frequently we will use something like the Unified Parkinson's Disease Rating Scale or UPDRS, which is those tappies and clappies and this and watching you walk and wiggling around your arms and legs. And it may feel a little bit silly, but it really is quite meaningful. And especially standardized exams like that can tell us how a person changes over time, how a person changes in response to starting a medication. And so that's very, very useful. You don't need to practice the taps and claps in the car on the way to the doctor's office. People frequently ask about a DAT scan, which is a type of brain imaging, and this is usually not necessary to diagnose Parkinson's disease. If you have classic symptoms and the exam is consistent, the DAT scan does not tell us much more, and when we compare it to a movement disorder specialist, the doctor tends to perform better than the scan because the scan doesn't have the benefit of learning all about you. So when do we start treatment? The bottom line is the decision of when to start treatment is made through a discussion between the neurologist and the person living with Parkinson's disease. We start treatment when you tell us that your symptoms are getting in the way of some portion of your life. If they are crossing a threshold where they are bothersome enough that you want to do something about it, then we should be starting treatment. And again, what that treatment looks like is so different for every person. So you got to build a team. At different points in the Parkinson's journey, you need to seek the support of professionals who can help with treatments and symptom management. And the answer is not always just add on another pill. There's so much more to this. So your team may include a movement disorder specialist or specialty trained neurologist, a general neurologist, your primary care doctor, a nurse, a physical therapist, occupational therapist, speech language pathologist, social worker, psychologist, psychiatrist, pharmacist, the list goes on, dietitians, fitness professionals, support groups, community health workers, and more. So where do you start? I would advocate to start by finding your point person, find the quarterback, find whatever sports analogy you want. Finding a qualified physician is the first step. Look for a neurologist who treats people with Parkinson's disease, and when possible, a movement disorder specialist. What does that mean? Movement disorder specialist is a neurologist. They've done 4 years of their residency training after medical school, and then they have gone on and spent 1 or 2 extra years just focusing and training in Parkinson's disease and related disorders. It's all that we think about. So how do you find such a person? Starting with the Parkinson's Foundation, going to the Parkinson's Foundation website, calling the helpline is a great place to start. You can look up a Parkinson's Foundation Center of Excellence or places that have a movement disorder specialist and go from there. So some people may not have a specialist in their area or a doctor who knows Parkinson's well. Telemedicine may be a good option, but it might also be worthwhile to travel once or twice a year, even if it's far, a farther distance, to see a specialist who can then coordinate your care and work together with a local physician to provide the best possible care for you. It's really important to find someone who you're comfortable with, who's going to take the time to listen and answer your questions. If you don't feel like it's the right fit for you, you know you best, look for someone else, find your team, because it's going to be your team for years to come. So I mentioned that Parkinson's treatment can include medications, can potentially include surgery for some people, but exercise and other specialized therapies are critical. Exercise, PT, OT, speech, counseling, and therapy. So briefly, we'll talk about medications. Different medications work in different ways. Different regimens are prescribed for different people because everyone is different. Not only their Parkinson's, but what other medical problems they have, what other medications they might be on. There is no cookbook for this. There is no cookie cutter approach to Parkinson's disease. You are too individual. You are too unique. The choice of medicine may be dictated by side effects and tolerability. It may be dictated by the symptoms that bother you most. In general, levodopa is sort of our oldest, our standby. It is both our safest medication and our most powerful. And rarely are those two characteristics found in the same medication. So why is this? Well, levodopa, once it crosses the blood-brain barrier, which is kind of this protection system, it's almost like saran wrap around the brain. Once levodopa gets to where it needs to go and gets to your brain, it's converted to dopamine. So I told you before that Parkinson's is often thought of as a dopamine issue because you're losing your own dopamine. You're not producing as much. Well, levodopa gives you back your dopamine. It's sort of like if someone is B12 deficient, we give them back B12. We don't give them back some B9 and some B3 and kind of hope that it adds up together. But levodopa can have side effects just like any medication. And so we have other alternatives. We have other things in our toolkit. We have medications that kind of mimic dopamine, so dopamine agonists. We have MAOB inhibitors, and these are medications that aren't quite as strong, but they block the breakdown of dopamine. They kind of prevent it from being recycled. They keep it in the neighborhood a little bit longer. And similarly, COMT inhibitors, they also kind of boost the efficacy. They kind of increase the levodopa that we're giving you. They keep it around for a little bit longer. So surgery can be an option for some people, not for everyone, but surgical options can be explored if symptoms aren't well controlled with medication alone. So what are we talking about? Deep brain stimulation has been around for quite some time. This is almost like a pacemaker in the brain. So instead of treating the issues going on in Parkinson's with chemical medication, we can replace some of that chemical medication, not usually all of it, but some of it with electrical stimulation. No, you don't feel shocks, but it does help, particularly with tremor, particularly with people that are getting a lot of fluctuations where the medicines work and then sort of don't work, and you go through cycles throughout the day, or a lot of dyskinesias, a lot of extra fidgety, wiggly movements. That's who deep brain stimulation typically tends to work the best for. Duopa is another option, and this is an intestinal pump, sort of like a feeding tube in a way, but it is a small tube where the levodopa is delivered directly to your intestine. It's like a slow, continuous drip of levodopa, and that's used to treat motor symptoms. These can be wonderful treatments for the right patients, but surgery isn't right for everyone. So like any therapy, talk to your doctor about whether this is an option for you. What is and should be an option for everyone is exercise. So Everyone knows that they should be exercising more. This talk is being recorded at the beginning of January. We've all made our resolutions, right? Stick to them, especially people with Parkinson's. Why? There's all kinds of reasons, but we know that people with PD who start exercising early after their diagnosis, even if you've been a couch potato up until now, if you start exercising now and you can get to a minimum of 2.5 hours a week, 30 minutes, 5 times a week, you will experience a slower decline in your quality of life compared to the folks that are still sitting on the couch. So even if you haven't been an exerciser, you are now, you can be now. So why? Exercise helps maintain balance, mobility, strength, and flexibility. This is critical. Some of the things that can wind people with Parkinson's up in the hospital are falls. So even if you have no balance issues right now, fantastic. Let's build on that strength and get better and more stable. Exercise can also help to ease secondary symptoms like mood and constipation. Exercise programs should include flexibility and stretching exercises, aerobic activity, stuff that really gets your heart rate up, gets you sweating a little bit, and resistance training. And people frequently say, okay, but what's the best exercise? Like if I'm going to buy one piece of equipment, it's the thing you'll do. It's the thing you'll stick with and enjoy. I am not a runner. Running is never going to be the thing that I do, but find the thing that you love. If that's biking, if it's running, if it's Tai Chi, if it's yoga, if it's Pilates, if it's boxing, if it's karate, if it's dance, if it's, walking your dog or chasing after the grandkids and playing a really vigorous game, do it. If you can switch it up and incorporate a few things, even better. But do whatever you will stick with and enjoy. Why? Because exercise is fundamentally changing the brain. There is neuroplasticity, so helping your brain change over time in good ways, right? Helping the brain maintain old connections, form new ones, try to restore lost ones. You're basically nurturing the environment of your brain by exercising, by reducing toxic chemicals, increasing the production of other chemicals that help sort of sustain the brain and nourish the brain by exercising. So who can help you with this? Physical therapists are whizzes at keeping you moving as well as possible, as long as possible, and enhancing your ability to move. They can show you how to use those random machines at the gym. They can show you what you can do from the comfort of your own home, what you can do in your neighborhood. You can tell them, here's what I'm struggling with. You can practice falling and then getting up. It sounds silly, but it's critical. Occupational therapists often work on how you can adapt to activities of daily living, how to do things better, using your personal strengths, changing your environment, and adapting activities. Speech language pathologists are critical to help maintain communication skills, strengthen them, strengthen your voice, and combat swallowing difficulties. So early intervention, especially if there's any change in swallowing, is really important because there are things that we can do about it. So people often find this surprising, but depression and anxiety are the #1 factors impacting the overall health and well-being of people with PD. It's not the tremor, it's not stiffness, it's mood. And this makes a lot of sense because if you're sad, if you're feeling blue and that's untreated, if you're feeling stigma against yourself for feeling blue, you're not going to take your meds, you're not going to exercise, you're not going to do all the therapies, right? And so this is treatable. It is important. It is imperative that we treat it. So mental health support for the person with Parkinson's disease, treating the mood disorders, whether that's with medication or non-medication strategies, discussing the challenges of living with Parkinson's disease, building coping skills throughout the PD journey, is important for the person living with Parkinson's disease, but is equally important for the mental health support of the family, the friends, the care partners surrounding that person with Parkinson's disease. This is not a disease that affects an individual. This is a disease that affects a family, a partnership, an orbit of everyone that's living and being with that person with Parkinson's. Mental health support can be provided in numerous ways, and this is not an either or, this is an and or all of the above. Support groups, social workers, counselors, psychologists, neuropsychologists, and psychiatrists. There are so many challenges of living with Parkinson's disease, and this is just scratching the surface, but unpredictability, sense of control or lack of sense of control, loss of independence, changes in lifestyle, changes in roles, changes in identity, but there are so many things that you can do about these, that your loved ones, that the team that you build around you can help. So what do you do about unpredictability? There's some thought that getting comfortable with unpredictability, and with a sense of control, knowing that, some days you may need to go with the flow. Some days won't be great days, and some days will be great days. Sometimes you can predict that, and sometimes you can't. And kind of riding that wave when you can. Finding things that you can take ownership of. Your exercise routine, how you think about Parkinson's, how you talk to yourself about Parkinson's, and your attitude. Instead of thinking about what things you can't do or that you might need more help with, thinking about what you can do and reaching out to physical therapy, occupational therapy to maintain your independence, to find ways around and workarounds. Reconfiguring your lifestyle. If there are things that are hard, it doesn't mean you need to give it up, but can you work those a little bit differently? And instead of reflecting on roles that may change, finding the light in those roles that have changed, creating new roles for yourself, and reflecting on your identity. Parkinson's should never define you. This is not who you are. This is a thing on your list. This is part of your life. It is not the entirety of your life. How do we make it less and less a part of your life? We move forward. We develop new treatments. We find new answers. We figure out the unmet needs for people with Parkinson's, and we try to meet those needs. And the way that we do that is through research. Truly, research plays a vital role in helping us understand Parkinson's, and there's a research study for everyone, for anyone. Research leads to new treatments and medications. Research doesn't mean necessarily a clinical trial. It might mean a survey. It might mean participating in a behavioral intervention, a program, an exercise study. It could be anything. But research provides us better understanding of symptoms and disease progression. 10 years ago, we would have said, no, vision doesn't change in Parkinson's. That's not a thing. We know now that it is. We used to think pain wasn't a part of Parkinson's. We know now that it is. And all of this is because of research. So how can you get involved? Ask your doctor, ask your movement disorder specialist, reach out to the Parkinson's Foundation, look at clinicaltrials.gov. You can go on this website, type in Parkinson's disease, type in a radius of how far you'd be willing to travel to participate in a study, and boom, you get this list of all of the different studies going on to look at Parkinson's. And even if you don't want to participate in a trial, but you just need a little shot of hope on one of those bad days, go look at clinicaltrials.gov, see how much is going on. Research has not stopped in Parkinson's because of COVID or anything else. Everyone is still really hard at work trying to make this a thing of the past. So in conclusion, Parkinson's does not define you, and Parkinson's can be treated effectively. Symptoms vary from person to person. You will never meet someone else with the same Parkinson's as you, and it can include both movement and non-movement symptoms. A personalized treatment approach with a comprehensive team of providers can help individuals have the best long-term outcomes. Critically, a support network is helpful for people with Parkinson's and their families. You cannot go it alone. You should not go it alone. We are here to help you, Parkinson's specialists, all of the team, and the Parkinson's Foundation. So with that, I want to thank you so much for your time, for putting in the effort to learn more about this disease. It will only make you stronger. Thank you so much.
Dr. Fleisher, thank you so much. That was an incredible, incredible presentation. So much information and so many very helpful practical tips. I can't thank you enough. As you can imagine, we have received many questions in advance as people registered, and we received a number of good questions during the presentation as well. And I'd like to start with a timely one, if we could. One of our viewers writes in that she's really concerned about many of her patients with Parkinson's and how COVID has been impacting the follow-up care that people need but are struggling to do because of the risk of exposure, like going somewhere for PT or exercise, or even having a clinical PT come into their home. What do you suggest? What are your thoughts about that so we can help to manage this until we can get rid of COVID?
Absolutely. I think it's a great question, and it's something that we are thinking about 24/7, it seems, for the last almost year now. I think this is an area where telemedicine, as much as we're all sick of Zoom and we're sick of, all these different ways of not being together in person, this is a silver lining of this pandemic, is that for better or worse, we've all been forced to spend a lot more time in front of computers, and we can do physical therapy like that. We can do speech therapy. We can do occupational therapy. We can do doctor's visits. For a while, all of my clinic visits were like this. And it's not perfect, but it's absolutely better than not getting care or not seeing the therapist. Sometimes I'm reminded that, perfect is the enemy of good. And with so much bad and challenging going on, this is a good. And so find a therapist who knows Parkinson's, and even if they're farther away, but you can see that person this way, that is a huge benefit.
Absolutely. And I would encourage everyone, if you're having difficulty finding some of these online resources, check in with our helpline. They will definitely help you. And in addition to that, as part of PD Health at Home, our Friday series is Fitness Fridays. So you can access fitness programs directly, very easily from your home in a safe environment.
Can I give a special shout out to Fitness Fridays? Because Joellen Fox, who leads most, if not all, of those Fitness Fridays, is a hero among us. If you don't like to exercise, or your loved one doesn't like to exercise, just tune in, please, because she will get you moving, and she will get you smiling as you move, which is really something impressive. She is fabulous at what she does.
Absolutely. And know that it's not like necessarily an hour long. There's all different kinds. So you can take your pick and build slowly to get into the Fitness Friday group. So please take advantage of that, all free to you from the Parkinson's Foundation. Another viewer asked about gastrointestinal pain and the gas and bloating that we know is just so common. Can that be successfully treated with dopamine, or is there other treatments that should be used?
That's a good question, and that could be an entire talk. I would say for the most part, the dopamine treatments on their own are typically not enough. But on the flip side, if the GI issues aren't addressed well, then you may not be absorbing your dopamine medications as well. And so it can have the opposite effect of, sort of if your gut isn't right, everything else is kind of off too. So yes, there are a lot of things that we can do. Constipation is so very common. And there are a lot of different things that we can do to try to address that constipation, get people moving, feeling back to themselves. And because that can be a really slow symptom that kind of creeps in over years and years, it may seem like that's your normal. But for a lot of people, that's not their normal. Right. And once they kind of get on track and find, the diet and the hydration and, different things to try to get at that constipation, they feel much better. Exercise helps with that as well. So again, like everything else, talk with your doctor, talk with your team. A gastroenterologist can be really helpful. A nutritionist can be really helpful for some of these things.
Absolutely. Great. Okay. And another person asked, any relationship between stroke and PD?
That's a good question. Not that I am aware of. We know that we used to think that there was no real relationship between like diabetes and Parkinson's, for example. And diabetes is a big risk factor for stroke. We know that people with Parkinson's are more susceptible to insulin resistance. So even if you don't have a family history of diabetes, you may have more insulin resistance, which puts you at risk of diabetes. And that down the line can be a risk factor for stroke. But Parkinson's itself is not typically associated with stroke.
Thank you. This next one is a bit of a tough question, but I think it's really important that we try and address it. And one person tuning in today said, PD was discovered in 1817 and we still have no cure. And you're absolutely right. We should all be saying, why is that? And in this case, this person reports that he or she shows no difference when using Cinemet. And I've heard other people talk about that. Maybe Dr. Fleischer, you could address that a little bit?
Sure. So let me take those one by one. So the first is no one wants to see Parkinson's gone more than those of us who every single day are talking to so many people affected in so many different ways and wishing we had something more to offer. And so many of us who are physicians are also scientists. There are lots of scientists out there working to find a cure. And unfortunately, as just watching how COVID has affected different people differently, right? And it's just one virus. There's no real genetics involved. It's just a virus and you just catch it like a cold. But some people have minimal symptoms and other people are completely knocked out by it or die from it, right? Parkinson's affects so many different areas of the brain and so many cascades of symptoms that identifying sort of, here's what looks like Parkinson's symptoms wise, and here's what that looks like in the brain, and the variability from person to person tells us just how complex this is underneath. Um, Finding genes that are related, some genes that are causal, but again, that's a really small fraction of people. But that's led us to say, okay, well, it's this molecule. This molecule might not be the end all and the be all, but this is really something. And so there are entire, many labs working on just that molecule, just that protein, because that may hold a clue. But there are so many of those different clues in sort of this Parkinson's pathway. And so I wish that there was one answer like COVID and we could just go after a virus, go after a protein, but it's not that simple. It is frustratingly complex, and like almost anything else in the brain, the more we learn, the more we recognize just how much more we have to learn. But there are so many people trying to do that learning and so much going on along the way. So yes, we want a cure. We want a cure for diabetes. We want a cure for high blood pressure. Honestly, I had a surgeon tell me, if you want to cure something, you got to be a general surgeon. Take out an appendix. Everyone else is just treating disease. And so hopefully soon.
This question reminds me of what you said earlier about if you've met one person with Parkinson's, you've met one person. It's
Right.
so unique to each individual. And I think this is probably a good time for me to plug our PD generation study. This would be a great thing for as many people to get involved with as possible. Just go to our website, parkinson.org/PDgene, or you'll find it right on our landing page too. The more we know, the better off we'll be. We can advance therapies, get to find out what is going on.
Exactly. People talk about personalized medicine, often in the sense of cancer. And if you see, all the commercials on TV for different drugs, for different types of cancer, those are personalized in the sense of certain cancers are this gene positive and this receptor negative and this, blah, blah, blah. And if you have a medicine that targets just that right combination of things, that's kind of the key to unlocking that flavor of that cancer. And that's where a lot of these studies in Parkinson's and with the genetics of Parkinson's are headed, is to say, Parkinson's isn't one Parkinson's. This is, you go into the ice cream shop and which of the 31 flavors of Parkinson's do you have? And that's an underestimate, right? And so if we know the genes, then we can create targeted treatments along with everything else. And I think that gets at the question of, why doesn't levodopa work for me? And I think that there's sort of 2 points to that, is what symptoms are you measuring the medicine working by? So for some people, they may only have a tremor, or that may be their most bothersome symptom. And levodopa and a lot of our treatments can be really good at tackling the slowness, the stiffness, the impaired dexterity and fine finger movements, but not super great at tremor. And so if tremor is your main thing and you start taking the medicine and you're going, well, my tremor's still here, then it seems like you are levodopa unresponsive and it doesn't do anything. But it may be that, the medicine doesn't quite match up with the symptom that we want to treat. On the flip side, there are some people for whom levodopa just doesn't work as well. And that can happen within Parkinson's. Sometimes that also makes us kind of take a step back and think, is this truly Parkinson's disease, Or could this be one of the related cousin disorders? And sometimes the only way to know that is following a person out over time to see, how do their symptoms evolve? What symptoms evolve? How do you respond to medication? Because a lot of people start kind of on the same hiking path of Parkinson's, and sometimes people peel off in one direction and go towards some of these cousin disorders. And I joke that the last doc you see is always the smartest, and it's only because we have the benefit of time to look back and go, yeah, there was maybe some clues back down there, but we only know that with the benefit of time.
Again, the complexity of all of this. Thank goodness we have so many very smart people working on it. So I'm going to keep going with a few more questions. I want to try and get in as many as we can. Dr. Fleisher, can you talk about natural supplements and if you suggest what's been studied? How about glutathione? Supplements, medications, can you say a few words about that?
Absolutely. So I talk with patients about this every single day, and people come in with their list of the things that they're taking. And I think the really important thing to recognize is, what is a supplement? What is a medication? What is a chemical? Right? So I explained to my 6-year-old the other day, he wanted to know, is water a molecule? Is water a chemical? It is. Basically everything in our world is a chemical. And so, some chemicals come from plants and things, but those are still chemicals. And so some supplements, are often derived from natural products. A supplement, the difference between a supplement and a medication really is that a supplement is some substance, some chemical that has not been subjected to FDA regulation. Basically, they haven't had to put up or shut up with the claims that they're making. So anyone can put forth a chemical and say it does the following. We did all kinds of studies. We're not going to show them to you, but we did all kinds of studies. We're going to throw some numbers and some flashy stuff at you, and it's great. And that can be a supplement. And typically they may be very expensive. They may not, and they may claim data, but you really want to see that data for yourself. And if you don't feel comfortable, interpreting that data, that's what we're here for. So a supplement isn't regulated. No one is checking that whatever they're saying it does, it actually does, or that what they say is in the bottle is actually in the bottle. There are thus far, many supplements have been studied for Parkinson's, and none, when we compare them head to head with a placebo, none have been shown to improve symptoms or slow the course of progression more than placebo. So the
evidence isn't there to support that. Yeah. Okay. This is, I think, a really important question as well. They're also important. What, if anything, can be done to help with vision problems? I've heard people talk about this many times. Can you address that?
Absolutely. So there have been some great articles published recently, just, reviewing sort of vision problems in Parkinson's disease, which again, we didn't think was a thing a couple of years ago. It's a thing. And so seeing an ophthalmologist, in particular, seeing a neuro-ophthalmologist, which is either someone who's trained as an eye doctor and gets additional training in neurologic conditions that affect the eye, or vice versa, a neurologist who gets that extra training, they will have sort of, their finger on the pulse of what Parkinson's does to the eye, which is that it can affect things sort of in the eyeball itself, dry eye, frequent blinking, just a sense of grittiness, things like that, for which certain drops and ointments can be really helpful. Parkinson's also affects the way that your brain interprets the images that you're seeing. So even if everything's fine in the eyes, once that information gets to the back of the brain and has to be sort of sorted out to say, what is it that I'm seeing? That can be really challenging in Parkinson's. And an ophthalmologist or neuro-ophthalmologist can help pinpoint sort of where are the issues. Is it the eye, the brain, both? And then really work on different things. So double vision, there are things that we can do, the dry eye, the blurriness, and then also ruling out other stuff that's treatable, the low-hanging fruit of, is it a floater or could this be the beginning of a hallucination, right? And helping to sort those out can be really helpful and really reassuring.
Very good. We've also had several questions, people inquiring about end-stage Parkinson's, if that is in fact a phrase. I'm not quite sure if that's accurate, but I understand how people and why they're asking. what does it look like? What can we do? How can we support people who've lived with this disease many, many years?
Yeah, so I think a couple of things. Number one, there's no agreed upon end stage. There isn't even really agreed upon terminology yet. Some people refer to advanced Parkinson's disease. Some people talk about late stage Parkinson's disease. And what exactly that means is kind of in the eye of the beholder. There's a lot of work going on and wonderful minds thinking about how do we define this better and how do we come up with a staging system or some kind of scale that really captures everything. Right now, the staging system that we have for Parkinson's is kind of a 5-point staging system. And most people don't get into stage 4 or 5 because something else gets them first. Parkinson's is not the thing that is the cause of death for most people. Most people die with Parkinson's, not because of. But late stage Parkinson's can look like mobility being impaired to the point of needing assistive devices to walk, like a walker, or being dependent on a wheelchair. It can mean that sometimes we are balancing, sort of treating the motor symptoms, the stiffness, the slowness, the tremor, with the complications that can come from that, sort of the meds working and then not working. And that's really a function of having Parkinson's for so many years and treating it for so many years. And the non-motor things, which can be cognitive changes, hallucinations, delusions, and those, it becomes this very, it's a balancing act of, using medication to help with one, but it could worsen the other. Well, then you maybe could use something else, and that balance is constantly shifting. And it's different for every person. So it does look different for everyone, but common things that can happen as someone progresses: more difficulty with swallowing, unintentional weight loss, sometimes because of that trouble swallowing. So nutritional issues become really important. Making sure that someone is taking small bites, getting a swallow evaluation, using our speech and language pathologists who can be just lifelines, and preventing falls. Some falls are unpreventable, but there are a lot of falls that are preventable with the right steps and making the home environment safer, and then detecting infections early on, because our folks can get urinary tract infections and pneumonias, and instead of showing up with the typical symptoms, it shows up as a sudden change in your Parkinson's symptoms. Parkinson's is a slowly progressive disease. It doesn't change overnight. If the symptoms change overnight, it is something else, but it's going to show up through your Parkinson's. And so I think that's the red flag, is if you wake up one morning and it is a urinary tract infection, it's COVID, it's a pneumonia, it is something else.
And this will be our last live question for the day. And this comes from a caregiver, care partner. And it's a couple different times we've been asked, how about the situation where the person with Parkinson's is perhaps what we might think of as apathetic, really doesn't want to get up and do things? Could you take just a few moments to discuss that?
Absolutely. I think that this is one of the silent but deadly pieces of Parkinson's. And I think that caregiver who asked the question is particularly astute at recognizing it, because for many people, what this shows up as is a caregiver saying, I know my loved one is supposed to exercise, take their meds on time, go to therapy, do whatever it is. And I keep telling them, and they don't want to do it. And sometimes apathy comes with depression, that there's sadness, there's, feelings of hopelessness, but sometimes apathy is its own thing. It's just this loss of motivation. It's like someone poked a hole in the gas tank of motivation and it's just drained out. And unfortunately, we don't have good treatments for this as far as medications. And so what I tell people, what works the best, is really to acknowledge that this isn't your loved one with Parkinson's not appreciating your efforts, not recognizing that they may realize, yeah, I know I should exercise, just don't feel like it today. I'll do it tomorrow. But the same story happens day after day, right? And it's recognizing, I tell my caregivers, I am deputizing you. If your loved one with Parkinson's, if you are the person with Parkinson's and you're angry at your care partner for nagging you, don't be mad at them. They're doing it because we're telling them to. And that's because that is the thing that will keep you moving and keep you doing better for longer. You have to keep moving if you want to keep moving. You have to keep moving if you want to keep moving.
Makes
And
sense.
so you have to exercise. You have to, come up with an individualized daily schedule. And sometimes I tell people, make a contract, write it down. And if the caregiver goes, but I want you to do these 5 things every day, and the person with Parkinson's goes, I don't want to do any of those, I'll agree to 1. Compromise, make it 2. Renegotiate the contract a month
There you go.
later,
Yeah.
right? But come to something where you agree, I'm going to do some of the things.
Excellent. Dr. Fleischer, I cannot thank you enough for this just unbelievably wonderful program today. Thank you for helping us launch it. I'd like to thank all of our viewers for tuning in with us today. We're so glad that you are here with us. And keep in mind that there are tons of questions we didn't get to. Call our helpline 1-800-4PD-INFO. Go to our website. There's so much more that you can get, and you can get a live person to talk to as well. And I know that there are people tuning in from really quite literally all over the world, but I wanted to make sure that if you don't know what your chapter is for the Parkinson's Foundation, you can go to parkinson.org/chapters and find which area of the country, which chapter you are covered by. And you can be in touch, get involved. We want you to get involved. As we said, keep moving. Moving day, Parkinson's, there's so many things. Join the community. We're all here to support you. Thank you so much for tuning in. Stay safe. And we look forward to seeing you at one of our next programs. Thanks, everyone.